Well, hello and welcome to Dr. Childress Answers Your Questions. Today, in this segment, I'm going to be discussing a question from a targeted parent about how targeted parents can change or stop the allied parent from creating so much problem in the family and with the child. And the answer is basically we can't. That it's the prognosis or the prediction that we're going to be able to change the allied parent, the pathological parent, the problematic parent, is very low for a variety of reasons. And this is where diagnosis becomes critical in understanding treatment and what's happening in the situation. And there's a couple of diagnoses that are involved here that kind of lock things into place. And once we understand what the diagnosis is, perhaps there's things we can do, but not necessarily with changing the pathology within the allied parent. We can change how it manifests, how it's being expressed, and various things, but not so much what's happening with them. The first diagnosis that kind of locks things into place is a shared or induced persecutory delusion in the child. And that's coming from the primary case, which is the pathological narcissistic borderline dark personality parent, the allied parent. And a delusion, a delusional thought disorder, is a fixed and false belief maintained despite contrary evidence. Maintained despite contrary evidence. That there's no amount of contrary evidence that we can provide to them regarding the false nature of their belief that is going to change their belief, despite contrary evidence. So we could present them with contrary evidence to their false belief from now until forever, and it's not going to change a delusional belief because that's the nature of a thought disorder. They need that thought disorder for a variety of reasons that will not allow them to change their belief system. So that's the first issue: is when we're dealing with a thought disorder, a persecutory delusion, that's impervious to change. For more about the pathology, I have a video up on the patterns of pathology and describes it from a variety of perspectives. But the delusional thought disorder that rises from the transgenerational transmission of trauma and stuff, they're actually kind of living in the past and believing the present is the past, and it's getting kind of confused for them. And so that's not a changeable thing. The second diagnosis that kind of locks this into place is the factitious attachment pathology imposed on the child, a factitious disorder imposed on the child, a false attachment pathology. And that's being imposed on the child for secondary gain to the parent. They're getting rewards from creating pathology in the child. And the two domains of rewards are first, the manipulation of the court's decisions around child custody, creating pathology, attachment pathology in the child, in this belief that the child's being malevolently treated in some way, the persecutory delusion works. If they create pathology in the child and get the child to adopt a victimized child role, then they get awarded basically full custody of the child because the mental health system is really bad in the family courts. And so the courts aren't getting information, accurate information about the pathology in the family, about the severity and the nature of the pathology, the persecutory delusion, the child's psychological abuse. None of that information is being provided from the mental health system to the family courts because the mental health system is fabulously broken. Forensic psychology is a failed experiment in service delivery. They are absolutely awful. They just need to go away. We need to get clinical psychology back and get a diagnostic assessment that the court can then use relative to what's in the family, persecutory thought disorders, child psychological abuse, and those sorts of things. But the second domain of rewards or secondary gain that is provided to the pathological parent from creating pathology in the child is to their own emotional and psychological needs. So the borderline can, avoid abandonment and meet their own personal needs on that. But more specifically, the need that's being met is the spousal psychological and emotional abuse of the targeted parent using the child as the weapon. And in weaponizing the child into the spousal abuse, they create such significant pathology in the child that it rises to the level of child psychological abuse. But fundamentally, at its core, this is a spousal abuse pathology. So they create the delusional thought disorder and the attachment pathology, the factitious attachment pathology, and all the child's pathology. They create that in weaponizing the child into the spousal abuse. So we have two dangerous pathologies involved: child abuse and spousal abuse. The psychological abuse of the child and psychological emotional abuse of the spouse is the driving fundamental issue. And so, in terms of changing the motivation and the behavior of the allied parent, it's working. The child is an effective instrument of spousal abuse being used against the targeted parent, and they get manipulate the court, and so independent of what the court decides, 50-50 custody or whatever, the child's pathology will manipulate the decisions of the court to get the pathological parent full custody. So until we change the rewards that are being given to the pathological parent for creating this severe attachment pathology in the child, then it's working, and there's no expectation that they would be motivated to change things. It's working for them. So what we need to do on this situation is first get an accurate diagnosis. First, get the diagnosis of child psychological abuse by the allied parent, the factitious attachment pathology, and the shared persecutory delusion. Once we get an accurate diagnosis, that will then guide our treatment decision making and the court's decision making surrounding the child. Because in all cases of child abuse, physical abuse, sexual abuse, neglect abuse, or psychological abuse, we always protect the child. That's what we do. And so when the diagnosis of child psychological abuse is returned, we need to shift the custody over to the healthier parent, the targeted parent, and provide a period of protective separation from the pathology and the twisted parenting of the allied parent so that we can recover the child's healthy and normal range development. Because if we're trying in therapy to restore a child's attachment bond to a parent, meanwhile, the pathological parent is trying to keep the child symptomatic, then we're just going to rip the child apart in the differing motivations. So the treatment team and the targeted parent are trying to get the child to bond, and the pathological parent's trying to keep the child symptomatic, and the child's caught in the middle. And so, in order for our treatment to restore the healthy development of the child, we need a period when that pathological parent isn't trying to distort things. So it gives us a little space to recover the child. And the estimate is about 90 days, about 3 months for a typical mental health professional. That would be the expectation. In 3 months, we can get a healthy child back, given the nature of the pathology. And so we need that protective separation. We also need it relative to the treatment of the delusional thought disorder, because if the child has a delusion, a thought disorder, that the targeted parent is somehow abusive, that they're being malevolently treated in some way by the normal range parenting of the targeted parent, we need to balance that. We need to confront and challenge that false belief system. That's what we do with delusions. We never validate a delusion. If somebody believes the CIA is poisoning their food, We don't like, oh my goodness, you need to call the police. And no, it's a delusion, it's a thought disorder. And we say, well, I know you believe that, but that's not actually the case. And so we challenge delusional beliefs, which is again why diagnosis is so important. It guides treatment. And so that protective separation period allows us to communicate to the child that the rest of society here, the courts and the mental health professionals, have deemed that the allied parent, their parenting is problematic. And it rises to the level that we need a child protection response. That's how problematic we see that. And also, we're communicating to the child that we view the targeted parent as normal range. They're not a danger. The child's not being malevolently treated in some way. There's no need to protect the child from that parent. And so that is a essential communication to make to the child when the child's in a shared persecutory delusion, an induced persecutory delusion. That also, though, requires that the mental health professionals and the court have a great deal of confidence that the allied parent is psychologically abusing the child and that the targeted parent represents no risk to the child. And because we're going to be making decisions on treatment based on that diagnosis and the confidence we have in that diagnosis. So that's again where we need to get a proper risk assessment for child abuse to the appropriate differential diagnoses that the mental health professionals can rely on for treatment and that the court can rely on relative to its custody decision making. So in all of these cases of court-involved pathology involving attachment displays or attachment pathology by the children, surrounding custody conflicts, we need to just routinely get them out for a proper risk assessment for child abuse to the appropriate differential diagnoses so that we know what to do. Treatment-wise, we can make treatment-related decision-making. Custody-wise, we can make the custody decisions based on an accurate diagnosis. So then if the allied parent is creating the pathology and is getting rewarded for creating the pathology, how do we deal with that parent? We get the protective separation, but we're not going to keep the child separated forever from a parent. So eventually, at the end of 3 months, when the child's recovery is stabilized, we're going to be restoring contact with the abusive parent. Now, in the rest of child abuse, let's say physical child abuse, we separate and protect the child, recover the child's healthy development, then restore with the physically abusive parent with safeguards in place, like supervision of their parenting because they're a violent parent. And we don't want to just leave them unsupervised with the child until we're reassured that they're no longer a violent parent, which may involve some additional therapy that they're getting, collateral therapy, they're developing insight, and we're getting feedback about that. And so that's how supervision would be applied to the physical abuse. But supervision doesn't work with psychological abuse because the psychological abuse is carried in the relationship, not in the physicality. And so if the parent has access to the child, they're just going to be all over the, the supervision. The supervision isn't going to do any good. They're just going to move right around it and manipulate the child in very subtle ways and that can't be stopped. So then what do we do about protecting the child when we restore with the abusive parent? What we do is we apply outcome measures, and we use those outcome measures to monitor whether or not the child abuse is resumed. And if the child's symptoms go back down to ones and twos on our outcome measure, then we know the child abuse is there. We have to take steps to protect the child again. And so the outcome measure I recommend is ratings on a 1 to 7 scale, a Likert scale, for affection, cooperation, social involvement that made by the targeted parent on a daily basis and sent over to the therapist, and then they discuss those ratings in therapy and whatever was happening during the weekly therapy. But those ratings of 1 and 2s allow us to then basically tell the child and the allied parent that if the child drops to ones and twos again, and that's going to indicate to us that the child abuse by the allied parent has resumed, and then we're going to separate the child again because they're started beating the child psychologically with electrical cords, psychological electrical cords, so we have to protect the child again. And what that does is reverses some of the secondary gain that's being created for the rewards to the allied parent for creating the pathology. Because right now, if they create pathology in the child, the attachment pathology, the rejection of the targeted parent, that is an implied allegation that something about the targeted parent is abusive. The child's rejecting the parent, they must be abusive. Once we get an accurate diagnosis and it's the allied parent who's abusing the child, then when the child becomes symptomatic, the allegation goes the other direction. And so now it's not meeting their needs. Their need was to get everybody accusing the targeted parent of being abusive. Now, if they create pathology, they're being accused of abusing the child accurately. And so it's not meeting that need anymore. In addition, instead of getting the child by creating pathology in the child, instead of getting custody, the targeted parent now gets custody of the child if they create. So it's reversing all how the symptom confers power, and it's no longer being rewarded for the pathological parent. Once it stops to its function, once it stops being rewarding to the pathological parent, then there's no motivation to create the symptoms anymore because it's not working. In fact, it's doing just the opposite. Now, a more formal way to do this is the contingent visitation schedule that's up on Amazon that I developed. It's a strategic family systems intervention in the kind of the cover of a behavioral intervention. And basically, what it does is it defines a successful day and then a successful week for the child based on these ratings 1 to 7 on affection, cooperation, social involvement. And so, if the child has 5 out of 7 successful days, let's say a week on, week off, kind of 50-50 custody, for as an example. So, if the child has 5 successful days and maybe 2 off days, that's okay. But basically, 5 out of 7, that's a successful week. And if they have a successful week, everything stays at the court ordered 50-50 or whatever the court orders. But if the child has less than 5 days in a 7-day period, less than 5 successful days of 3 or higher, then the time with the pathological parent goes down. The time with the allied parent goes down, and the time with the healthy normal range parent goes up, so we can fix the problems that are being created, and so that we can eliminate or reduce the distorting influence and the psychological abuse of the pathological parent. And so the child, if the child doesn't have 5 days, they have to earn 3 consecutive successful days. And as soon as they have 3 consecutive successful days, boop, it pops back up again to whatever the court said it should be. 50-50 custody would be typical, and with no makeup days. So whatever gets lost from the allied parent gets lost. This, again, this is a more formal way of removing the motivation for creating the pathology in the child. So instead of getting the child's custody of the child, the allied parent, and making an allegation of child abuse against the allied parent, it just reverses it around. If the child is pathological, the targeted parent gets more time with the child, and the allied parent is identified as the abusive parent. So, in shifting around how the symptom confers power within the family, it removes the motivation from the pathological parent to produce symptoms because it's not working anymore. It's not psychologically or emotionally abusing the other parent. They're getting more time with the child, and it's not getting the social everybody to accuse them of child abuse and giving custody over to the pathological parent. So none of it's working anymore under the contingent visitation schedule. So that's a more formal way of controlling for the parent. But actually changing the parent and what's happening is very unlikely because of the nature of the pathology. So mostly it's just managing or controlling how the expression of what their pathology is rather than actually eliminating the pathology or getting empathy for the child. They have no empathy for the child. They will destroy the child's life in order to meet their own needs and as a weapon of spousal abuse. And they don't have any insight and they don't have any capacity for empathy. So, with that, I'm going to wrap up this segment and good luck to everybody out there. And I will answer your questions until you have no more questions. In 5 years, 10 years, however long that is, I'll just keep answering your questions. So, with that, take care, everybody, and we'll talk with you later.